Hello, welcome. Thank you for coming today. My name is Jordan Tishler. I'm a physician, and we're going to talk about medical cannabis. What is it good for, with some practical details and emphasis on EDS. First, let me tell you just a little bit about myself so that you know where I'm coming from. Yes, I went to Harvard Medical School. I trained in internal medicine at the Brigham and Women's Hospital here in Boston. And then I spent most of my career working as an emergency room physician, and the last 15 years or so was at the VA Medical Center. And through that process, I came to be interested in medical cannabis. As you can imagine, in my experience there, I saw hundreds, if not thousands, of veterans whose lives were remarkably harmed by substances. And by substances, I really mean alcohol, numbers 1 through 9 on the top 10 list, and then a smattering of other things. And it was in 2011 when Massachusetts started thinking about a referendum for medical cannabis that I sort of had my aha moment, and I thought, well, isn't it interesting? I've seen all these veterans who've been so harmed by these other substances, and I've never seen anybody harmed by cannabis. So that led me to think, well, maybe it's not that dangerous, and maybe we should look at, what the utility might be for cannabis as a medicine. So that started me down a several-year path of doing my homework, in which I came away from the process feeling, there was actually some pretty good evidence that cannabis could be used as a medicine, but that it had to be used carefully and in controlled doses so that we get the best from it and avoid some of the risks. I've then been able to go back to my colleagues and teach them a bit about this kind of medicine and for whom it would be beneficial and for whom it would be contraindicated. And that has worked out really well. And it led me then to form the Association of Cannabis Specialists, which is a now international not-for-profit, where we focus on educating clinicians who are specializing in cannabis medicine, as well as educating those who are not going to do this kind of medicine, but need to know enough to understand who might benefit from this. And the other thing that we focus on is working on the national issues around medical laws and the legalization of cannabis for medical use, because we think that that's a very important part of the upcoming process. And we really need to enhance the ways in which physicians and other clinicians can take care of their patients. Just as a matter of disclosure, I don't have anything to disclose. There are many types of symptoms that we can address with cannabis, some of which are more or less germane to EDS. And certainly pain is a huge issue for EDS patients. We know that of all problems, pain is the #1 presenting complaint in primary care. And it's also one of those areas where patients tell us that, frankly, the conventional options aren't really doing a very good job. And if you think about it, there really aren't that many conventional options. And if there are any reasons why you can't take any of those, then we're sort of stuck with opioids. And we all know that opioids aren't that good. And frankly, they aren't that safe. By bringing cannabis into our treatment arsenal, we significantly increase our options, and we can use cannabis alongside with other conventional medications, including opioids. But we know that opioids and cannabis are roughly equally effective for mild to moderate pain. And that allows us to start with cannabis, which, as you know, is significantly less dangerous. We also know that for severe pain, cannabis is less effective, and we may in fact need some opioids. So we don't want to throw the baby out with the bathwater. We need to see these all as usable tools for the care of patients. We also know that for patients who come in already using opioids, the introduction of cannabis as a pain medication can lead to reductions in their opioid need by somewhere between 40 and 80%, depending upon the study that we're looking at. So all around, this is a good thing. We get better pain control and we use fewer opioids. Certainly, anxiety and depression often go along with EDS, and we know that cannabis can be useful for these problems, but we also know that the sort of accepted conventional approach, which is typically kind of wake up in the morning and smoke some weed, is actually not effective, and it makes things worse in terms of provoking anxiety and decreasing school and work performance. On the other hand, small amounts of cannabis given typically in the evening or before bedtime can be very effective. Well, let me rephrase that. Can be somewhat effective. Cannabis overall for anxiety and depression is a fairly weak medication. And so if somebody is needing an SSRI, for example, and is already on it, it is unlikely that cannabis is a good substitute, but it may be able to help us get better control. And it also may be that they may be experiencing some of the side effects of SSRIs, and cannabis can help alleviate some of those. So they play nicely in the sandbox. The other thing that we should think about is insomnia. This is the #2 complaint throughout the nation, and it is, I think, the thing that cannabis actually does best of all. As with many things, the approach to the problem depends upon the specifics of the problem, and certainly insomnia is one of these areas where people fall into different categories. Some people have trouble getting to sleep, other people have trouble staying asleep, and some very unfortunate people have trouble with all of the above. And so our approach to treating this will vary depending upon what sorts of problems. Up in #4, you can see anorexia, and don't get me wrong, this is not meant to be anorexia nervosa, which is a mental health condition. This is the medical word anorexia for poor appetite, and this is something that we see a lot with people who have chronic illness and who lose weight, and certainly cannabis can be used gently to provoke provoke appetite. Nausea and vomiting hopefully doesn't feature too much in the EDS population, but is certainly something we see, for example, in cancer chemotherapy, and that's an area where we can address things with cannabis as well. And then #6, sexual dysfunction, is really an entire hour-long discussion in and of itself. I'd be happy to give that talk to you guys at some point, but suffice to say that there are very few medications that are available to help men with sexual dysfunction, and none that are available to help women with sexual dysfunction. And quite frankly, cannabis is a really good agent for addressing all of these concerns in all patients. Let us address some of the off-the-bat kinds of concerns. And one thing that people often ask me is, well, isn't it addictive? And the answer merits some discussion. We have to remember that there are two different things that often get lumped into addiction. So there's dependence, which is a physiologic or physical adaptation to a substance like cannabis or any other, in which case, when the body adapts and gets used to it, if you stop giving it to that body, then your body gets grumpy and gives you symptoms that allow you, that tell you it's not happy with you. That's different from an addiction. An addiction is really a set of maladaptive behaviors that arise around the use or procurement of a substance. And so that's more of a psychological phenomenon, and they happen in different situations and different rates. Let's do a little comparison here. So the lifetime risk of dependence, again, the development of withdrawal symptoms for cannabis users is about 7%. If we compare that, for example, with nicotine at about 32%, opioids in that 25%, and 17 to 18% for cocaine, and also not mentioned on the slide are benzodiazepines, and about 15% for alcohol. So some of these substances are commonly available, others of them are used medically, and we can see that even compared to the least risky of those, being alcohol at 15%, cannabis is less than half as risky. It's also important for us to note that lifetime risk isn't quite as easy as it might seem. For all of these substances, except cannabis, the lifetime risk is constant, meaning whether you're 25 or 45, if you pick up opioid use, you have a 1 in 4 chance of becoming dependent on it. Cannabis, on the other hand, is front-loaded, meaning your risk is higher if you are a teenager or young adult. In that case, your risk of dependence is actually that same 17 to 18% that we see for cocaine and for benzos. But if you make it to the ripe old age of 25, your risk then drops to about 2 to 3%. So in the vast majority of adults, we can say the cannabis risk of dependence is very small. It's also important for us to ask the question, well, what does this withdrawal look like? I think we all have an image, thank you Hollywood, of the guy sitting in a dingy apartment on the floor, sweating and screaming and vomiting and wanting to die. And that is a rather sensational view of opioid withdrawal, but has nothing to do with cannabis. Cannabis withdrawal tends to be somewhere between 3 to 7 days of insomnia and crankiness, much of which mirrors what we may be treating, but nonetheless, we can say that these responses are not particularly dramatic. The other thing that people bring up is, well, will it make me stupid? And we've got many years of studies that look at things like IQ testing and functional MRI testing in healthy volunteers, aka recreational users. And over time, we have come to the conclusion that there may be some decrement in verbal function, but not in executive function, spatial or quantitative functioning. And we have to remember that these are recreational users, so we don't know how much they were using truly, but in fact, most likely they were using significantly higher doses than what we would be using in medical patients. And this was only seen after 20 to 30 years of heavy use, whatever that actually meant. I think far more instructive are some of the more recent studies that have actually been done on cannabis patients. And so here's a study from Dr. Stacy Gruber at Harvard that looked at these cognitive impairments. And what she found was that actually patients' cognitive function gets better. The theory is that being sick isn't very good for your cognitive function. And so by treating the illness with cannabis and making people feel better, their thinking gets better. Perhaps not back to where they were before they got sick, but certainly better than untreated. And so I have significantly less concerns for my medical patients around this issue. Let's talk a little bit about strains, CBD, and other cannabinoids. The first thing is we know that there are over 7,000 different types of cannabis. It's certain that the industry would like us to believe that each one of these different types is different and leads to different outcomes medically speaking. And therefore, as a patient, all you need to do is keep trying new and different strains so that eventually you find the perfect one. Well, that's great for selling a lot of weed. But when we really look at the question of, do these types actually influence the outcomes of medical conditions, meaning does it make my back stop hurting? The answer is strains do not seem to play any significant role. I tell my patients that we want strains that are of medium potency, but otherwise I do not specify strains because it doesn't really seem to make a difference, number one. And number two is, even if I told them go get X, when they got to the dispensary, they wouldn't have X anymore. Or if X worked, by the time they went back for more X, then there wouldn't be any. So it's kind of fruitless for me to be overly specific about things that don't matter. CBD is another area of concern. There's absolutely great evidence for the use of CBD in children with Dravet and Lennox-Gastaut syndromes, which are generally rare and severe seizure disorders that are genetically based. On the other hand, for almost every other use, pain, anxiety, etc., there's very little human data. There's very little data at all, and what there is mostly in rodents. Since human beings are not rodents, and it turns out that fully 92% of medications that work in rodents do not work in human beings, it's really impossible or unreasonable to generalize from those rat studies to human beings. In those studies, however, if we were to extrapolate, what we find is the dosing needed to provoke a reasonable response really exceeds the availability and cost that most people can tolerate. And last, it's important for us to understand that CBD doesn't cause intoxication, but it does do other things. And in particular, it can interact with conventional medications, and that can become quite problematic or even dangerous. And so this is something that we should probably be avoiding. It's also worth noting that there are other cannabinoids that are coming to be understood, and THCA is an important one. It's very abundant because that's what the cannabis plant makes, actually. And as long as it remains in the acidic or A form, it's not intoxicating, doesn't seem to interact with any other medications. And what we're finding is that it is 10 to 20 times better as an anti-inflammatory than CBD, based on actual human data. We don't yet, however, have randomized controlled trials and no head-to-head comparisons, so the story there isn't fully written either. I have been using it in some of my patients who have clear autoimmune disorders like rheumatoid arthritis and Crohn's disease and have been having great success. On the other hand, it's not clear to me at this point whether this is relevant to the EDS population. More to come on that. It's important for us to focus a little bit on the routes of administration, meaning how we take cannabis, because one of the things that's very interesting is that cannabis changes dramatically in terms of the way it behaves, depending upon how we take it. So everybody knows about smoking, and I think smoking is not a particularly good approach because smoke contains all kinds of toxins that we'd like to avoid, and frankly, lots of small particulates that aren't very good for our lungs as well. If smoking were the only approach that we had to the broader category of inhalation, then maybe it would be worth the risk, but we do have better options. So the options there are vaporization. And here you can see in the middle of the slide is something that people often call a vape or a vape pen. These, however, are dumb devices. They do not control for the temperature, or they don't control for the temperature adequately. And as a result, we're finding that they output the same toxins that we're getting from smoking. So these are things that we should be avoiding despite their current popularity. Above that, here with the fins and the little spout, is an example of a flower vaporizer. And what makes this different is that in the device itself, it has a little computer brain that's constantly measuring the temperature of what's going on in the flower. And that allows us to set that temperature to the right level and have confidence that it not only will get to that right level, but it will stay at that level. And then we're not burning anything and we're not making any of those toxins. That correct temperature, by the way, is 350 degrees Fahrenheit, as I always say, just like we were making cookies. Now, why are we talking about inhalation? Well, inhalation is important because it has rapid onset and relatively short duration. This makes it an ideal approach for problems that are acute or episodic. And the classic example I give is a headache, right? We don't know when a headache is going to start. We want to get in there quickly and knock it out. But then once we've done that, we'd also like the medicine to kind of go away. So inhalation is a great approach to things that pop up like a headache. The other end of the spectrum is things that we can take by mouth. Generally, not so much the cookies, but little gummies and that sort of thing. And what happens there is when we take it by mouth, it's actually converted by our liver into a different medicine that has different characteristics. So orally ingested cannabis is a bit slower to work, but when it works for longer. So this makes it our long-acting form of cannabis. And this is great for chronic pain, whether that's EDS or arthritis or knee injuries or that sort of thing. What we want is a nice level pain control, because we know that when pain bounces up and down like it would with the inhalation, that actually can make pain worse because people psychologically start to anticipate that pain. So in those cases, we really do better with those edibles. There are a bunch of other approaches that I will mention briefly. Down here, we've got an example of a tincture, which is a liquid extract of cannabis. And generally speaking, I tend to avoid these. There are two reasons. One is if you go to the dispensary, they talk about putting the drops under your tongue, and we know that doesn't work. Okay, what happens is then you swallow it and it gets absorbed, kind of like the edible, but it's not absorbed as well as a well-made edible. And because it's a liquid, it's awfully easy to make a mistake or not pay attention to the dosing, and that's when trouble arises. The other thing that's down here are some examples of topicals, creams, lotions, patches, and that sort of thing, which sound like a great idea. Again, particularly in the EDS community, where say a joint is particularly bothersome, would be lovely to rub some of this stuff on there. But what we know is that cannabinoid medicines won't go through your skin. And so while the rubbing has actually been shown to be helpful in terms of a placebo, it is not the cannabis in it that's making it work. And these things are insanely expensive. So I tell my patients, don't bother. Dosing is really the key to this. In this curve, you can see that when we advance the dose, we come to a place where we're getting the sweet spot, the maximum benefit and the least side effects. And cannabis, just like every other medicine, if you push the dose higher, you don't get better benefit, you just get more side effects. And so we really want to pay attention to that dose so that we get the best without the problems. In my practice, that works out to very small doses, typically somewhere between 10 and 15 milligrams. The other thing that comes up is that we have this really weird idea that you're supposed to go down to the doctor and they give you a card and off you go and, do what you do and listen to the bud tenders and all this stuff. And that seems kind of crazy to me. We want to get away from this concept of certification as a goal and really focus on safe and effective medical care. And close medical guidance and availability of the doctor is key to that. And that's true, or at least we hope it's true, in conventional medicine. We certainly need to improve that here in this country, but that's the theory anyway. And it's not just sort of like, oh, go talk to the bud tender and get some medicine. What we know, in fact, and unfortunately, is the dispensaries provide a whole lot of misinformation to patients in order to make a sale, and that ultimately is taking advantage of people and not providing the kind of care. In fact, worse than that, often derailing the plan that would otherwise have worked for that patient. Let me just take a brief moment to introduce the Association of Cannabis Specialists again, where our goal is to increase that standard of care for patients so that they're really getting the education and the guidance and the follow-up that they need. And we want to provide that to both our cannabis specialist physicians, those who are practicing this kind of medicine, as well as to our referring physicians, meaning the people who are out there on the front lines taking care of people who need to understand this medicine. We really want to work with dispensaries and product manufacturers to improve their products, as well as their approach to taking care of patients. We want to encourage research because we always can use more information. And perhaps most importantly, we want to improve the laws and regulations around cannabis on the national level so that we can be assured that patients are getting the care they need. Please take a moment to go to cannabis-specialist.org and check us out. This is my last slide, and I just want to say thank you all for listening today. If you're interested in some of the data that I've referenced here, you can go to this bit.ly link and it will pull up a list of studies that you can look at. If you want to get in touch with me, please feel free. Here's my email address, doc@inhalemd.com. I'm looking forward to the Q&A section, and we'll get to that shortly. Thank you again, and I look forward to hearing from you.